I've had a lot of people ask me what I've been up to. I'm gonna tell you.
I need you to look at the road. Have you ever heard of a thing called second sight?
Oh my god.
Is that drive?
No, but I don't want to tell you what drive is because...
Hey, is this drive?
Oh no.
Is this drive?
Oh my god, what are you doing?
I'm going to use your eyes to drive right now, alright? So I need you focusing on the road and on the road only, okay? I'm going to be using your eyes, so if you're just looking just there, then I'll be able to see exactly what we're doing.
Oh my god.
Straight, 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 straight.
Looking straight.
You having fun?
No! Oh! Oh my god, this is insane. Okay, you gotta turn, you gotta turn. Please don't crash over me, please don't crash. And there's another turn, there's another turn.
Okay, look, don't look away, don't look away.
I'm not looking away.
All right, so I saw the look on your faces, and some of you are looking like, what is this? This is dumb. Well, you do the same thing every day. And every single time that you treat blood pressure to some arbitrary target value, you're driving blind. And anytime you counsel a TBI patient about their expected outcome, you're driving blind. And almost every single day, when you rule out MI, you use high sensitivity troponin, and you use some arbitrary delta of 6, you are so driving blind, and you're no different from the guy in the video. And so part of my research work is to focus on these blind spots and to see if we can provide additional data to inform our practice. And there are 3 areas I want to talk about. The first is that there are no prognostic biomarkers for traumatic brain injury. So anytime there's a novel therapy, you can think of patients in 3 different groups. One, there are going to be people who are going to have a good outcome from that treatment. But then there are also going to be people who are going to have a poor outcome regardless of what you do. And then there are going to be people who have a good outcome regardless of what you do. And ideally, we really should not enroll these patients who are going to have a good outcome in the studies. But what do? Because we lack tools to distinguish between the different subsets of patients, we combine all these patients, and then we enroll them in trials, and then they crash, which is the name of the study. So what am I doing about this? So one of the things I'm doing in terms of solutions for prognostic biomarkers is that a co-investigator of TRACK-TBI. And TRACK-TBI is an NINDS-funded study that is an observational study that is enrolling TBI patients with the goal of enrolling 3,000 patients. 2,800 patients have been enrolled so far. And we're using a multi-marker approach to prognosis. And so we're looking at markers from a number of different brain cell types. So from the neuronal cell body, we're looking at UCHL1 and NSE. From axons, we're looking at neurofilament light chain, we're looking at total tau, we're looking at phosphorylated tau. And from astrocytes, we're looking at GFAP and S100B. And now in addition to these markers of brain cell injury, we're also looking at some inflammatory markers, things like TNF-alpha, IL-6, and IL-10. And hopefully putting all together, because the brain is such a very complex organ, we hope to be able to fully capture the complexity of underlying brain injury. And I do have some preliminary data that I want to share with you. And this was done using the Abbott iStat, which currently is able to measure both GFAP and UCHL1 and can get you results in about 5 to 10 minutes. So we looked at 454 CT negative patients who had TBI, who also had MRIs. So they all had normal head CT scans. And out of that number, about 30% had positive MRIs. They had MRIs of traumatic intracranial abnormalities. Now, GFAP levels were higher in patients who were CT negative and MRI positive than in those who were CT negative and MRI negative. And GFAP was able to distinguish between the CT negative, MRI positive patients versus the CT negative, MRI negative patients with an AUC of 0.76, which is not shabby. And so what does this tell us? This tells us that my GFAP is better than your CT maybe, that the biomarkers can potentially identify brain injury that is currently not seen on head CT scan. The other problem I want to talk about is the lack of predictive and monitoring biomarkers in TBI. And so TBI is actually a really heterogeneous condition, and it's made up of a lot of different brain injury subtypes. However, what do? We put all of them in one basket, and then we enroll them in clinical trials. And so if you have a drug that is, say, targeted towards cerebral edema, and all you do is you enroll severe GCS, using such a crude scale as severe TBI, using a crude scale of GCS to put people into your study, you're not really targeting people who are going to most benefit from your new treatment. And so it's sort of like saying, I have a drug for cancer, and so I'm going to enroll everyone, prostate cancer, breast cancer, lung cancer, just bring them all in. The drug is not going to work. It's best to figure out the clear subtype that will most respond to the novel treatment. And so there are a number of things we're doing in this area as well, and I'm going to just talk about our work with monitoring biomarkers. And you probably have heard from prior talks and from Cindy's talk as well about Dr. Lam's lab and their work with valproic acid. And so they did a study where they treated pigs that were subjected to TBI, with high-dose valproic acid, and they showed that high-dose valproic acid improves their neurologic outcome. And so what we did was measure two biomarkers, GFAP and NFL, in these pigs. And the graph on this side, pointer. So the animals who had saline had much higher levels of GFAP than animals that had VPA. And this is measuring the biomarker levels over the first 10 days post-injury. And we saw something similar with NFL, that animals who got saline alone had much higher biomarker levels than those who had VPA. And so this tells us that by measuring biomarker levels over time, we can actually get a sense of whether a drug is working or not. And so we may not have to wait until 6 months, to get the GOSE. While we wait for that, we can figure out if the new treatment is having biological effect, if it's having neuroprotective effect, if less neurons are dying. And to extend this work further, we're going to be looking at humans, since this was a pig study, where there was a recently funded study that is being run by the Siren Network called Boost 3. And Boost is going to randomize TBI patients to treatment with ICP measurement and partial brain tissue oxygen measurement versus ICP measurements only. And we're going to be measuring biomarkers in these patients as well and get serial measurements over time and see if we can see biochemical or biomarker effect of the treatment. We're going to do something similar, hopefully, in HOBIT as well. And HOBIT is a study that is randomizing patients to different doses of hyperbaric oxygen treatment. And again, we're going to look to see whether over time, as patients get treated with hyperbaric oxygen, whether we can see effect of treatment on brain injury biomarkers as well. Two other studies I want to quickly mention are Optimize TBI, which I'm the PI of. We're currently enrolling patients in our ED. We're treating patients with either high-dose fish oil or placebo. And we're also measuring biomarkers to see if high-dose fish oil, as was demonstrated in animal studies, is having neuroprotective effect. And then I'm going to quickly mention that a donor to the Department of Neurosurgery has funded a study of concussion in University of Michigan athletes. And one of the co-PIs, and starting this fall, actually starting from next month, we're going to start enrolling patients in the swim team. and then we'll enroll patients in men's and women lacrosse. It's been hard to get to the football team. But the plan is to enroll Michigan athletes and to determine whether biomarkers can help us identify those who are concussed and whether it can help us get a sense of return to play. One other thing we're doing is that we're building a device for continuous measurement of blood-based biomarkers. And this was funded by the Massey Award. And what we're hoping to do is build this device, which is going to be a point-of-care device that can allow you to measure biomarkers every 30 minutes. And then the results will be wirelessly projected either to a monitor or to the iPhone. And because, just the single snapshot of biomarker measurement by themselves are not good enough. You have to understand the longitudinal variability in biomarker levels. And so this will hopefully help us get to that. And finally, I told myself about 2 years ago I was not going to do ACS work anymore, but we just started using high-sensitivity troponin in the emergency department, and there are lots of opportunities to do great work. However, if you look under the hood of high-sensitivity troponin, you really do not want to see what many people see all the time, and you probably have noticed some of it. But some of the issues are, one, we're using a cutoff of 19, which is based on one paper. The rest of the world uses a cutoff of 14. Are we doing the right thing and everybody else is wrong, or not? We have to figure that out. We use a delta of 6. I've already mentioned that was like, which way is the wind blowing, and we chose 6. We need to back this with data. There is enough evidence that we're doing a disservice to women because when they have myocardial infarction, they release less troponin than men. And so there's a strong push to use different cutoffs for men versus women. But we're using just one cutoff. Do we need to be using different cutoffs? We have to figure that out. With the use of high-sensitivity troponins, we're diagnosing a whole lot of type 2 MIs. And we need to figure out more precise ways to distinguish between type 1 and type 2 MIs. So these are some of the things that we're going to try and solve in the troponin registry in building. Fortunate enough to have 2 students who are very dedicated to making phone calls and doing chart reviews, and so hopefully we'll be able to build a very well phenotyped database. But just a quick diversion, if you know of Eugene Braunwald, he was one of the first people to describe unstable angina. And in 2013, he wrote a commentary in Circulation. And he basically was saying, unstable angina is dead. And the truth is, with every passing generation of high-sensitivity troponin assays, fewer and fewer people get diagnosed with unstable angina. And so, to me, it's just vanishingly rare. And so one of the questions we're going to be asking in this registry is trying to understand the risk of adverse cardiovascular events in patients with recent onset symptoms who have no ECG changes and who have no dynamic troponin values. Because in my mind, those patients need nothing else. They can go home, they don't need a stress test, they don't need a CT coronary, they're done. The second thing I want to mention is that we're also looking at the kinetics of troponin, looking at how troponin values change over time. I had this one patient, I don't know if it's hard to see, but they had undetectable troponin at presentation, and then in 2 hours it went up to 19. And then we got an I, which is a different story, but then the troponin peaked within 8 hours of it coming up. Now, if you have looked at a ton of troponin values and you see this, you should immediately realize that this patient is unlikely to have obstructive coronary artery disease because the time to peak is just so short. Most people with obstructive coronary artery disease take a longer time to peak. And so by understanding the kinetics, we can be able to get a sense of etiology of myocardial injury. My time is over. I want to thank all the different funding agencies, and I have a lot of people who've helped me with the work, and I'm so grateful to them for all of their help. But really, there's no need to drive blind when you can see.